Good day. My name is Hannah Jamaica Delfin, together with my partner,
Patricia Marie Delgado,
and today
we were going to present
the respiratory tract drugs. So for today's agenda, we're going to discuss first the introduction of respiratory tract drugs. Next is the drugs for asthma and chronic obstructive pulmonary disease that fall into two principal, which are anti-inflammatory drugs and the bronchodilators. And lastly, drugs for allergic rhinitis, cough, and colds. So what is respiratory tract drugs? These are the drugs used to treat respiratory conditions. It falls into several categories: cough suppressants, bronchodilators, expectorants, and decongestants. Antibiotics and anti-inflammatory drugs are also important in the treatment of many respiratory diseases. What are the types of respiratory tract diseases? To be discussed by Ms. Patricia Marie Delgado.
so the first respiratory disease is asthma. Asthma is a chronic inflammatory disease characterized by inflammation of the airways, bronchial hyperactivity, and bronchospasm. Allergy is often the underlying cause. Asthma is a chronic inflammatory disorder of the airways. In about 50% of children with asthma and in some adults, airway inflammation results from an immune response to known allergens. In the remaining children and almost adults, the cause of airway inflammation is unknown, although as yet unidentified allergens are suspected. The next is chronic obstructive pulmonary disease or COPD refers to a group of diseases that cause airflow blockage and breathing-related problems. It includes emphysema and chronic bronchitis. COPD makes breathing difficult for the 16 million Americans who have this disease. Symptoms of COPD result largely from two pathologic processes: chronic bronchitis and emphysema. In most cases, both processes are caused by exaggerated inflammatory reaction to cigarette smoke. Chronic bronchitis, defined by chronic cough and excessive sputum production, results from hypertrophy of mucus-secreting glands in the epithelium of the larger airways. Emphysema is defined as enlargement of the air space within the bronchioles and alveoli brought on by deterioration of the walls of these air spaces. Among individuals with COPD, the relative contribution of these two processes can vary. So, what are the drugs for asthma and COPD? The major drugs for asthma and COPD fall into two main pharmacologic classes: the anti-inflammatory agents and bronchodilators. The overview of major drugs for asthma and chronic obstructive pulmonary disease. In the inflammatory drugs, we have glucocorticoids, the leukotriene modifiers, the chromalin, the omalizumab, and the roflumilast. In the bronchodilators, we have beta-2 adrenergic agonists, the methylxanthines, the anticholinergic and beta agonists, and cholinergic antagonist combinations. The anti-inflammatory drugs, especially inhaled glucocorticoids, are the combination of the asthma and COPD therapy. These drugs are taken daily for long-term control. Most people with asthma require these drugs for management at some point. What are the anti-inflammatory drugs? First, the glucocorticoid or glucocorticoids rather. For example, budesonide, fluticasone are the most effective drugs available for long-term control of airway inflammation. Administration is usually by inhalation, but may also be in IV or oral. Adverse reaction to inhaled glucocorticoids are generally minor, as all reaction to systemic glucocorticoids taken acutely. However, when systemic glucocorticoids are used long-term, severe adverse effects are likely. Then, the glucocorticoid inhalation use. Inhaled glucocorticoids are first-line therapy for management of the inflammation component of asthma. Most patients with persistent asthma should use these drugs daily. Inhaled glucocorticoids are very effective and are much safer than systemic glucocorticoids. For oral use, oral glucocorticoids may be required for patients with moderate to severe persistent asthma or for management of acute exacerbation of asthma or COPD. The adverse effects of inhaled glucocorticoids. These preparations are largely devoid of serious toxicity, even when used in high doses. The most serious concern is adrenal suppression. The most common adverse effects are oropharyngeal candidiasis and dysphonia, or hoarseness and speaking difficulty. For the oral glucocorticoids, when used acutely, less than 10 days, even in very high doses, all oral glucocorticoids do not cause significant adverse effects. However, prolonged therapy, even in moderate doses, can be hazardous. Potential adverse effects include adrenal suppression, osteoporosis, hyperglycemia, peptic ulcer disease, and in young patients, growth suppression. The leukotriene modifiers. Leukotriene modifiers suppress the effects of leukotrienes, which are compounds that promote smooth muscle constriction, blood vessels, permeability, and inflammatory response through direct action as well as through recruitment of eosinophils and other inflammatory cells. In patients with asthma, these drugs can decrease bronchoconstriction and inflammatory response, such as edema and mucus secretion. Three leukotriene modifiers are currently available. These are the Geliton, Zaferlucas, and Montelukast. Geliton blocks leukotriene synthesis. Zaferlucas and Montelukast block leukotriene receptors. All three drugs are dosed orally. The Geliton is an inhibitor of leukotriene synthesis. Is approved for asthma, prophylaxis, and maintenance therapy in adults and children 12 years old and older. Symptomatic improvement can be seen within 1 to 2 hours of dosing. The adverse effects of gelatin can be injure the liver as evidenced by increased plasma levels and of alanine aminotransferase activity. A few patients have developed symptomatic hepatitis which reversed after drug withdrawal. To reduce the risk of serious liver injury, all activity should be monitored. The recommendation schedule is once a month for 3 months, then every 2 to 3 months for the remainder of the first year and periodically thereafter. The Zafir Lucas was the first representative of a unique group of anti-inflammatory agents, the leukotriene receptor antagonist. The drug is approved for maintenance therapy of chronic asthma in adults and children 5 years and older. The adverse effect. The common side effects of Jaffer Lucas are headache and gastrointestinal disturbances, both of which are infrequent. Arthralgia and myalgia may also occur. Like Zelyuton, Lucas can cause depression, suicidal thinking, hallucination, and other neuropsychiatric effects. A few patients have developed Church-Strauss syndrome, a potential fatal disorder characterized by weight loss, flu-like symptoms, and pulmonary vasculitis or blood vessel inflammation. The Montelukast, a leukotriene receptor blocker, is the most commonly used leukotriene modulator. The drug has three approved indications. First, the prophylaxis and maintenance therapy of asthma in patients at least 1 year old. Second, prevention of exercise-induced bronchospasm in patients at least 15 years old. And the relief of allergic rhinitis. The adverse effect. Montelukast is generally well tolerated. In clinical trial, adverse effects were equivalent to those of placebo. In contrast to Diluton and Dapirlucas, Montelukast does not seem to cause liver injury. As with Dapirlucas, Church-Strauss syndrome can be occurred when glucocorticoids dosage was reduced. And then the bromelain. Bromelain is an inhalational agent that suppresses bronchial inflammation. This drug is used for prophylaxis, not quick relief in patients with mid to moderate asthma. Anti-inflammatory effects are less than with glucocorticoids. Therefore, bromelain is not preferred drug for asthma therapy. When glucocorticoids create problems, however, bromelain may be prescribed as alternative therapy. The therapeutic uses chronic asthma. Bromelain is an alternative to inhaled glucocorticoids for prophylactic therapy for mild persistent asthma. When administered on a fixed schedule, bromelain reduces both the frequency and intensity of asthma attacks. In exercise-induced bronchospasm, bromelain can be prevent bronchospasm in patients at risk for EID. For best result, bromelain should be administered 10 to 15 minutes before anticipated exertion but no longer than 1 hour before exercise. In allergic rhinitis, intranasal bromelain can relieve symptoms of allergic rhinitis. The adverse effects. Bromelain is the safest of all anti-asthma medications. Significant adverse effects occur in fewer than one of every 10,000 patients. Occasionally, cough or bronchospasm occurs in response to cromolyn inhalation. The omalizumab or Xolair is a monoclonal antibody with a unique mechanism of action. Antagonism of IgE, a type of antibody. The drug is a second-line agent indicated only for allergy-related asthma and only when preferred options have failed. Omalizumab offers modest benefits and has significant drawbacks. The adverse effect. Omalizumab can cause a variety of adverse effects. The most common are injection site reaction, viral injection, viral infection rather, upper respiratory infection, sinusitis, headache, and pharyngitis. Early clinical trials suggested a very small risk for cardiovascular problems and malignancy. A meta-analysis of post-marketing studies revealed no significant increase in cardiovascular events between subjects taking omalizumab and a placebo. Roflumilast is a phosphodiesterase type 4 or PDA4 inhibitor. PDA4 is an enzyme that breaks down cyclic adenosine monophosphate or CAMP. The end result of this process is an increase in inflammatory mediators. By inhibiting the enzyme, roflumilast decreases the release of inflammatory products. This helps to prevent inflammation and decrease damage to lung tissue, thereby improving pulmonary function. The adverse effect. Psychiatric adverse effects are the most concerning. About 60% of those in clinical trials report events ranging from anxiety and depression to suicidal behavior. For this reason, it is not recommended for patients with a history of depression. Loss of appetite frequently occurs. Weight loss is common. 20% of patients in clinical trials lost between 5% and 10% of their pre-treatment weight. Bronchodilators provide symptomatic relief in patients with asthma and COPD, but do not alter the underlying inflammation that is part of the disease process. Accordingly, the most patients will require a bronchodilator, also use an inhaled glucocorticoids for long-term suppression of inflammation. Monotherapy is a bronchodilator is appropriate only when asthma is very mild and attacks are Delgado, an energetic agonist, is inhaled beta-agonists are the most effective drugs available for relieving acute bronchospasm and preventing EIP. Virtually all patients with asthma use these first-line drugs as a component of an asthma management strategy. The classification developed in types. Beta-2 agonists may be administered orally or by inhalation, and their effects may be brief or prolonged. All beta-oral agents are long-acting. Among the inhaled agents, some are some are short-acting and some are long-acting. With the short-acting inhaled preparations, effects begin almost immediately. Deep inhaled preparation, effect inhaled preparation effect most immediately, peak in 30 to 60 minutes and SAEAs are well tolerated. Systemic effects, tachycardia, angina, and tremor can occur, but are usually inhaled preparations, prolonged acting, inhaled LAB ingredients may increase the risk for severe asthma and asthma-related death when used in monotherapy for long-term control. To minimize risk, LABs should be used only in patients taking recommended medication for long-term control and only if the medication has been inadequate by itself. For oral preparations, the selectivity of the beta-2 adrenergic agonist is only relative and absolute. Then the methyl methylstatins. Methylstatins have a number of pharmacologic actions that give them therapeutic value. They relax smooth muscles, including those of the bronchi, esophagus, and gastroesophageal sphincter. They are central nervous system stimulants that can reduce fatigue and improve concentration. The dosage and administration for oral dosage must be individualized. To minimize chances of toxicity, doses should be low initially and then gradually increase. If a dose is missed, the following dose should not be doubled, because doing so could may produce toxicity. Smokers require higher than average doses. Conversely, patients with heart disease, liver dysfunctions, or prolonged fever are likely to require lower doses. Patients should be instructed not to chew the sustained release tablet or capsules. Product information should be consulted for compatibility. The intravenous theophylline is reserved for emergencies administration. Administration must be done slowly because rapid injection can cause fatal cardiovascular reaction. Intravenous theophylline is incompatible with many other drugs. Accordingly, compatibility should be verified before mixing theophylline and other substances. The anticholinergic drugs. Anticholinergic drugs improve lung function by blocking muscarinic receptors in the bronchi, reducing bronchoconstriction. Two agents are available, the embattleurin and the tiotropium. These drugs are approved only for COPD, but are used off-label for asthma. Both drugs are administered by inhalation. The adverse effect. Systemic effects are minimal because embrazopium is a quaternary ammonium compound and therefore always carries a positive charge. As a result, the drug is not readily absorbed from the lungs or from the digestive tract. The most common adverse reaction are dry mouth and irritation of the pharynx. If systemic absorption is sufficient, the drug may raise intraocular pressure in patients with glaucoma. Adverse cardiovascular events. are heart attack, stroke, and death. Glucocorticoid long-acting beta-agonist glucocorticoid and LABA combinations provide the anti-inflammatory benefits of the glucocorticoid in the bronchodilation. Benefits of the beta-agonist. These combinations are more convenient than taking a glucocorticoid and LABA separately, but have the disadvantage of restricting dosage flexibility. These products are not recommended for initial therapy. Rather, they should be reserved for patients whose asthma has not been adequately controlled with an inhaled glucocorticoid at home. All three products carry a black box warning about possible increased risk for asthma severity or asthma-related death from the LABA and the combination. However, because the LABA is combined with a glucocorticoid, risk should be minimal. The beta-adrenergic agonist, anticholinergic combinations. The combinations of a beta-agonist with a cholinergic antagonist optimizes bronchodilations by capitalizing the unique actions of the individual agents. As mentioned previously, beta-agonists promote bronchodilation by stimulating adrenergic receptors. In the lung, this relaxes smooth muscle in the airways. Cholinergic antagonists or anticholinergics promote bronchodilation by blocking cholinergic receptors. This relaxes smooth muscle tone by preventing stimulation of cholinergic receptors. So, what is allergic rhinitis? This will be discussed by Hannah Jamaica Delfin.
Allergic rhinitis is an inflammatory disorder that affects the upper airway. Major symptoms are sneezing, rhinorrhea or runny nose, pruritus or itching, and nasal congestion caused by dilation and increased permeability of nasal blood vessels. In addition, some patients experience associated conjunctivitis, sinusitis, and even asthma. Symptoms are triggered by airborne allergens, which bind to immunoglobulin, antibodies in mast cells, and thereby cause the release of inflammatory mediators, including histamine, leukotrienes, and prostaglandins. Allergic rhinitis is the most common allergic disorder, affecting almost 1 out of every 6 people in the United States. Allergic rhinitis has two major forms: seasonal and perennial. Seasonal rhinitis, also known as hay fever, occurs in the spring and fall in reaction to outdoor allergens, such as fungi and pollens from weeds, grasses, and trees. Perennial or non-seasonal rhinitis is triggered by indoor allergens, especially the house dust mite and pet dander. What are the drugs for allergic rhinitis? So these are the overview of drugs for allergic rhinitis. First is the intranasal glucocorticoids. Intranasal glucocorticoids are the most effective drugs for the prevention and treatment of seasonal and perennial rhinitis. Because of their anti-inflammatory actions, these drugs can prevent or suppress the major symptoms of allergic rhinitis. Congestion, rhinorrhea, sneezing, nasal itching, and erythema. The adverse effect of glucocorticoids are generally mild. The most common are drying of the nasal mucosa and a burning or itching sensation, sore throat, epistaxis or nosebleed, and headache may also occur. Systemic effects are possible but are rare at recommended doses. Of greatest concern are adrenal suppression and the slowing of linear growth in children. The preparation, dosage, and administration for glucocorticoids are administered using a metered dose spray device. Benefits are greatest when dosing is done daily rather than PRN. Full doses are given initially. After symptoms are under control, the dosage should be reduced to the lowest effective amount. For patients with seasonal allergic rhinitis, maximal effects may require a week or more to develop. However, an initial response can be seen within hours. For patients with perennial rhinitis, maximal responses may take 2 to 3 weeks to develop. If nasal congestion is present, a topical decongestant should be used before glucocorticoid administration. Next is antihistamine. Oral antihistamine are first-line drugs for mild to moderate allergic rhinitis. For therapy of allergic rhinitis, antihistamine are most effective when taken prophylactically and less helpful when taken after symptoms appear. Action and uses of oral antihistamine. These drugs can relieve sneezing, rhinorrhea, and nasal itching. However, they do not reduce nasal congestion because histamine is only one of several mediators of allergic rhinitis. Antihistamine are less effective than glucocorticoids. Antihistamine should be administered on a regular basis throughout the allergy season, even when symptoms are absent, to prevent initial histamine receptor activation. Because histamine does not contribute to the symptoms of infectious rhinitis, antihistamine are of no value against the common cold. Some patients take first generation antihistamines for their drying effect. However, this may be complicate the treatment of colds by increasing the viscosity of secretions and thus making them harder to expel. The result is thick, warm, moist, mucoid environment serve as an excellent medium for microbial growth. Adverse effects are usually mild. The most frequent complaint is sedation, which occurs frequently with the first generation antihistamine and much less often with the second generation agents. According, second generation agents are clearly preferred for students who need to remain alert in class and for patients who do work that requires alertness. Anticholinergic effects, drying of nasal secretion, dry mouth, constipation, urinary hesitancy are common with first generation agents and relatively rare with the second generation agents. Next is intranasal antihistamine. Two antihistamine, azilastin and olaputadine, are available for intranasal administration. Both drugs are indicated for allergic rhinitis in adults and children older than 12. Both drugs are supplied in metered spray devices. The usual dosage is 2 sprays in each nostril twice daily. With both drugs, systemic absorption can be sufficient to cause somnolence. Additionally, some patients experience nosebleeds and headaches with both azilastin and olopatadine. This drug can also cause an unpleasant taste. Next is the intranasal cromolyn sodium. Action and uses. For the treatment of allergic rhinitis, intranasal cromolyn is extremely safe, but only moderately effective. Benefits are much less than those of intranasal glucocorticoids. Cromolyn reduces symptoms by suppressing the release of histamine and other inflammatory mediators from mast cells. According the drug, Accordingly, the drug is best suited for prophylaxis and hence should be given before symptoms start. Responses may take 1 or 2 weeks to develop. Patients should be informed of this delay. Adverse reactions are less than with any other drug for allergic rhinitis. Preparation, dosage, and administration. For the treatment of allergic rhinitis, cromolyn sodium is available in a metered dose spray device that delivers 5.2 milligram or actuation. The usual dosage for adults and children over 2 years is 1 spray or 5.2 milligram per nostril 4 to 6 times a day. If nasal congestion is present, a topical decongestant should be used before cromolyn. Like the antihistamine and glucocorticoids, cromolyn should be dosed on a regular schedule throughout the allergy season. Adverse effect. The next is the sympathomimetics or decongestant. Action and uses. Sympathomimetics reduce nasal congestion by activating alpha adrenergic receptors on nasal blood vessels. This causes vasoconstriction, which in turn causes shrinkage of swollen membranes, followed by nasal drainage. With topical administration, vasoconstriction is both rapid and intense. With oral administration, responses are delayed, moderate, and prolonged. In patients with allergic rhinitis, sympathomimetics relieve only stuffiness. They do not reduce rhinorrhea, sneezing, or itching. In addition to their use in allergic rhinitis, sympathomimetics can reduce congestion associated with sinusitis and colds. Adverse effect, rebound congestion. Congestion develops when topical agents are used more than a few days, with prolonged use as the effects of each application wear off. Congestion becomes progressively worse. To overcome this rebound congestion, the patient must use progressively larger and more frequent doses. Once established, rebound congestion can lead to a cycle of escalating congestion and increased drug use. The cycle can be broken by abrupt decongestant withdrawal. However, this tactic can be extremely uncomfortable. A less drastic option is to discontinue the drug in one nostril at a time. An even better option is to use an intranasal glucocorticoid for 2 to 6 weeks, starting 1 week before discontinuing the decongestant. Next is the next is the anticholinergic or the route for this is nasal. Action, block nasal cholinergic receptors and thereby reduce secretions, do not decrease sneezing, nasal congestion, or postnasal drip. Then the adverse effect is nasal drying and irritation. Lastly is licotrins. Route oral. Actions block licotrins receptors and thereby reduce nasal congestion. For the adverse effect, rare neuropsychiatric effects. Next is cough. What is cough? Cough is a complex reflex involving the CNS, the peripheral nervous system, and the muscle of respiration. The cough reflex can be initiated by irritation of the bronchial mucosa as well as by stimuli arising at sight distant from the respiratory tract. Cough is often beneficial, serving to remove foreign matter and excess secretions from the bronchial tree. The productive cough that is characteristic of chronic lung diseases Example, emphysema, asthma, bronchitis should not be suppressed. For example, not all coughs, however, are useful. When a cough is non-productive, creates discomfort or deprives a patient of comfort or sleep, suppressant medication is appropriate. The most common use of cough medicine is for the suppression of non-productive cough associated with the common cold and other upper respiratory infection. What are the drugs for cough? First is the antitussives. Antitussives are drugs that suppress cough. Some agents act within the CNS, others act peripherally. The antitussive falls into two major. First is the opioid antitussive and second non-opioid antitussive. Interestingly, although the major antitussive is the codeine, dextromethorphan, and diphenhydramine, are clearly effective against chronic non-productive cough and experimentally induced cough. There is no good evidence that these drugs can suppress cough associated with the common cold. The next is other non-opioid. Diphenhydramine is an antihistamine with the ability to suppress cough. The mechanism is unclear. Like other antihistamine, diphenhydramine has sedative and anticholinergic properties. Cough suppression is achieved only at that doses that produce prominent sedation. The usual adult dosage is 25 milligram every 4 hours. Next is the opioids antitussives. Opioid antitussives, all of the opioid analgesics, have the ability to suppress cough. The two opioids used most often for cough suppression are codeine and hydrocodone. Both drugs act in CNS to elevate cough threshold. Hydrocodone is somewhat more potent than codeine and carries a greater liability for abuse. Next is non-opioid antitussives. Dextromethorphan is the most effective over-the-counter non-opioid cough medicine and the most widely used of all cough medicine. Like the opioids, dextromethorphan acts in CNS. Next is cold. The common cold is an acute respiratory infection of viral origin. Between 50% and 80% of colds are caused by the human rhinovirus, which can also cause serious infection of the lower respiratory tract. Characteristic symptoms of the common cold are rhinorrhea, nasal congestion, cough, sneezing, sore throat, hoarseness, headache, malaise, and myalgia. Fever is common in children but rare in adults. Colds are self-limited and usually benign. Persistence or worsening of symptoms suggests the development of a secondary bacterial infection. In the United States, the economic burden of the cold is estimated at more than $60 billion a year. There is no cure for the cold, so treatment is purely symptomatic. Because colds are caused by viruses, there is no justification for the routine use of antibiotics. These agents are appropriate only if a bacterial co-infection arises. There is no evidence that vitamin C or zinc can prevent or cure colds because no single drug can relieve all symptoms of a cold. The pharmaceutical industry has formulated a vast number of cold remedies that contain a mixture of ingredients. This combination cold remedies should be reserved for patients with multiple symptoms. In addition, the combination chosen with multiple should contain only those agents that are appropriate for the symptoms at hand. Patients who require relief from just a single symptoms, example rhinitis, cough, or headache, are best treated with single drug preparation. Combination cold remedies frequently contain two or more of the following. First, a nasal decongestant. Second, an antitussive. Third, an analgesic. Fourth, an antihistamine. And five, caffeine. The purpose of the first three agents is self-evident. In contrast, the rules of antihistamine and caffeine require explanation because histamine has nothing to do with the symptom of a cold. The purpose of including histamine is not to block histamine receptors. Rather, because of their anticholinergic actions, antihistamine are included to suppress mucus secretion. This action can potentially worsen upper respiratory infections by thickening secretions, making them more difficult to drain. This may create an environment conducive to bacterial proliferation, which may lead to secondary bacterial infection such as sinusitis. Caffeine is added to offset the sedative effects of the antihistamine. Although they can be convenient, combination cold remedies do have disadvantage. As with all fixed dose combination, there is the chance that a dosage that produces therapeutic levels of one ingredient may produce a level of other ingredients that are either excessive or subtherapeutic. In addition, the combination may contain ingredients that the patient does not need. Furthermore, under U.S. Food and Drug Administration or FDA regulation, a brand name product can be reformulated and then sold under the same name. Hence, without carefully reading the label, the consumer has no assurance that the brand name product purchased contains the same amount of the same drugs that were present in the previous version of that combination product. Thank you so much for watching our presentation. Again, I'm Hannah Jamaica Delfin from BSN 2A together with my partner.
I'm Patricia Marie Delgado from DSM 2A.
And thank you and subscribe.